Hello and welcome back to the Irish Haematology Oncology podcast and to day 2 of our special daily dispatches from the ISOPP CAPhO Symposium here in Victoria, Canada. I'm your host, Eoin Tabb, bringing you the highlights from Friday's sessions. So if you missed yesterday's episode covering day 1, I highly recommend going back and having a listen to catch up on the discussions around BiTEs, B-cell ALL, closed system transfer devices and antibody drug conjugates. Day 2 was another incredibly varied day, starting with a deep dive into managing PARP inhibitors. We then had a thought-provoking session on culturally responsive care and traditional medicines, followed by a vital look at disaster management in oncology pharmacy and an increasingly important topic, sustainability in pharmacy and in our practice. The afternoon sessions then brought about practical insights into improving efficiencies in multiple myeloma treatment administration. There was a crucial update on managing opportunistic infections like CMV, consideration for treating older patients with hematological malignancies. And then there was a global perspective on oncology pharmacy survey levels from the ISOPP committee themselves, from research that they had undertaken, and finished with a critical update on the hazardous drugs list. A truly packed schedule. I'm wrecked after the day. So I suppose let's get straight into the key learnings from day 2. So the day was kicked off bright and early this morning at 7:15 with it's not 7:15, 7:45 with a lovely breakfast session. And this focused on new PARP inhibitor clinical resource. It was presented by Glenn Myers and Dr. Kumar. This resource endorsed by the Canadian Association of Nurses in Oncology, CANO, aims to support healthcare professionals managing patients on PARP inhibitors, specifically olaparib, niraparib, and talazoparib across breast, ovarian, prostate, and pancreatic cancers. It was a pan-cancer clinical resource. The session provided an overview of the resource itself, which covers PARP inhibitor mechanisms, the crucial role of genetic testing, both germline and somatic tumor testing for mutations like BRCA, and homologous recombination deficiency HRD testing in guiding therapy selection. It detailed the specific genetic testing requirements for different PARP inhibitors and tumor sites according to the Canadian indications. A reminder, I suppose, of how vital those biomarker testing is in this space. And the resource provides clear tables on dosing, duration, required baseline evaluations, including drug interaction checks. They highlighted potential for CYP3A4 interactions that needed dose adjustments for olaparib, for instance, and they recommended monitoring schedules like weekly bloods initially for niraparib. I'll include the resource in the show notes below here, and I might put it up on social media or something as well, because it's a very, very handy resource to have and gives you a great oversight of PARP inhibitors. A significant portion of the talk mirroring the resource used patient case studies to illustrate proactive and reactive management of common toxicities. So fatigue. So this was illustrated by patient Flora, a breast cancer patient on adjuvant olaparib. It emphasized that fatigue is often multifaceted, potentially linked to anemia, which is a common PARP inhibitor side effect, and significantly impacts quality of life. Management involves ruling out other causes, supportive measures, so diet, exercise, and sleep for fatigue, managing associated anemia, so monitoring that hemoglobin, potentially dose hold or reduce the dose of your PARP inhibitor, and considering patient quality of life when deciding on dose adjustments versus adding stimulants for fatigue. Then we had nausea. So this was illustrated by the patient Neil. A lot of alliteration going on in these slides. A prostate cancer patient on olaparib. This highlighted that nausea is common, often worse initially, and requires proactive antiemetic strategies. Management involves non-pharmacological advice, so small meals, hydration, taking meds with food, though caution needed if co-administered with abiraterone, which needs an empty stomach. Using appropriate antiemetics, so considering alternatives like olanzapine or ondansetron if metoclopramide fails, and again dose interruption reduction for persistent intolerable nausea. What was highlighted here is that often worse initially bit, but that nausea tends to reduce naturally over a 2 to 4 week period of patient starting. Then we also had hematologic toxicities and hypertension. This was illustrated by patient Hannah, who had ovarian cancer, and she was on niraparib. So this case focused on managing thrombocytopenia, common with niraparib, and it required dose holds or reductions based on platelet counts below 75, and hypertension, which was also common with niraparib. It stressed the importance of regular blood counts and blood pressure monitoring, adhering to dose modification guidelines, managing hypertension according to standard practice, so potentially needing additional antihypertensives, and remaining vigilant for the rare but serious risk of MDS and AML. This session concluded by highlighting the value of such practical clinical resources in standardizing care and optimizing patient management across different tumor types treated with PARP inhibitors, a kind of a global assessment tool and a global resource for managing PARP inhibitors. Again, I'll put it in the show notes below. Following the break of this, or following breakfast, Catherine Arnott and Adrian Tvet, sorry if I'm mispronouncing your name, presented on providing culturally responsive care, and it was drawing insights from the South Central Foundation's work with the Alaskan Native people, but framing the principles for, I suppose, a universal application for cultural considerations globally. The core message was the importance of moving beyond basic cultural competence towards cultural humility, acknowledging our own biases, recognizing power imbalances in the healthcare relationship, and committing to lifelong learning about the beliefs and practices of the patients we serve. A key part of the discussion focused on traditional healing practices and their integration with Western medicine. So using the Alaskan example, they described traditional healing involving ancestral knowledge, plant medicine used ethically and respectfully, spiritual alignment and connection to nature. So many patients use traditional or natural remedies alongside your conventional treatments. I suppose the pharmacist's role in this context, and nurse's role, and medical professionals' role in all of this is crucial. It involves open communication, so creating a safe space where patients feel comfortable discussing their use of traditional or natural medicines without fear of judgment. Respect, so acknowledging the value that these practices hold for the patient's holistic well-being. Information gathering, so asking respectful questions to understand what practices or remedies are being used. Undertaking a safety assessment, so identifying potential interactions between traditional remedies and prescribed medications, or the potential toxicities that certain plants or preparations have. While many traditional practices have minimal interaction risk, awareness is key, and natural databases should be utilized to assess these traditional medications or medicines. Supporting holistic care, so recognizing that wellness encompasses physical, mental, emotional, and spiritual aspects, and supporting the patient's chosen path to health, which may integrate multiple holistic approaches. Ultimately, the session stressed that adopting cultural, responsive, and humble approaches helps build trust, improves communication, and adherence to the medications from Western medicine, reduces health disparities, and allows pharmacists to provide truly patient-centered care. So then we went on to another section, another talk then, and it was Dr. Caitlin Watson. She presented a crucial session on continuing cancer therapy amid chaos. So a disaster management roadmap for oncology pharmacy. This I felt, I suppose, particularly relevant given increasing global events like pandemics, extreme weather events, I suppose conflicts that are occurring globally at the moment. The talk emphasized that disasters, defined as hazard plus exposure plus vulnerability, are increasing, partly due to climate change, and pose significant threats to the healthcare continuity. Cancer care is particularly vulnerable due to complex treatments, reliance on infrastructure, and the immunocompromised nature of our patients. The challenges that were highlighted including infrastructure damage, loss of records, displacement of patients and staff, treatment interruptions impacting outcomes, communication failures, and the exacerbation of chronic illnesses under these disaster conditions. So strategies to mitigate these challenges involve robust disaster preparedness, and the key elements of this preparedness include open communication, so between colleagues regarding plans and the patient's responsibilities. Patient education, ensuring patients understand their diagnosis, treatment plan, medication list, schedule, and how to access resources or contact staff during an emergency. Personal preparedness, medication reserves for the patients and evacuation plans for those patients is vital. That aspect of understanding their diagnosis, their treatment plans, medication list, etc. In the event of a cyber attack and we don't have access to the records, then sometimes the patient might become the key point of information to retain their information or to gain access to their information. And then the last bit, which was very important, was an all hazards approach. So developing flexible plans adaptable to various scenarios rather than a rigid disaster specific plan. So all of the events that could occur to a patient and all of the hazards that are associated to a patient can fairly be replicable across all disasters. So whether it is a cyber attack, a fire, a flood, it generally causes similar issues and that there is a lack of continuity of care. So basically developing your disaster management plan and to encompass all hazards, and maybe you can kind of pick and choose. They can't get access to their medications, or we've lost access to IT systems, so that you can kind of pick and choose depending on the disaster, but having it all encompassing rather than having a flood management plan. Okay, so pharmacists were positioned as essential responders with responsibilities across all phases: prevention, mitigation, preparedness, response, and recovery. Specific roles include ensuring medication supply chain logistics, managing emergency supplies, providing vaccinations, performing a medicines reconciliation, which is critical if records are lost, counseling on increased risks, so risks of infection, in the case of lots of natural disasters, and then also in the case of pandemics, providing psychological first aid, managing comorbidities, and participating in risk reduction strategies. So she outlined 7 key steps for pharmacy preparedness. So 1, capitalize on pharmacy visibility. At the moment, we're always stepping to the forefront for disasters. We're very adaptable and we have always gone above and beyond when a disaster occurs. Capitalize on that visibility now post COVID-19 and make sure that we're not forgotten about. So use an all hazards approach. As I was mentioning, assess organizational readiness. So maybe the use of simulation-based training to see how ready we are if a disaster did occur. Build adaptability and resiliency into your system. Understand the emergency management cycle. Clearly define the team roles during a disaster and provide emergency training. So the core message was that all pharmacists, especially in oncology, have a duty of care to prepare for disruptions and ensure continuity of central care during crisis. This went directly into another talk, and it kind of connected logically with that previous talk on disaster management. So Shaliza Sajwani, co-chair of the Canadian Association of Pharmacy for the Environment, presented on sustainability and pharmacy. This session highlighted the environmental impact of pharmacy practice and the urgent need for action. The talk defined environmental sustainability within pharmacy, encompassing 3 key areas. So 1, climate change, primarily driven by greenhouse gas emissions from energy use, transport, and specific medical products like anesthetic gases and some inhalers. 2, plastic pollution. So there was significant waste generated from packaging, single-use devices, and operational processes. Concerns were also raised about potential health impacts of plastic components like BPA. There was research that was very interesting on the screen, citing that there is possible interactions with the BPA component in plastic with agents like doxorubicin, significantly reducing the efficacy of doxorubicin. And pharmaceutical pollution, so the environmental contamination caused by improper disposal of medications or excretion of active pharmaceutical ingredients. And number 3, pharmaceutical pollution, so the environmental contamination caused by improper disposal of medications or excretion of active pharmaceutical ingredients. The presenter distinguished between climate adaptation, so that's protecting health services and patients from existing climate hazards like heat waves, floods, and supply chain disruptions, which is linking back to our initial disaster planning talk, and climate mitigation, which is actively reducing pharmacies' environmental footprint. Key impacts specific to oncology pharmacy were discussed, such as the effect of heat waves on medication stability, so using carboplatin, cisplatin stability data as an example, and 5FU stability as well. What do you do if your temperature goes up to 40 degrees and you have no air conditioning? And also the vulnerability of complex supply chains in those heat waves. Mitigation strategies suggested for pharmacy included sustainable procurement practices, reducing plastic waste through operational changes and supplier engagement, reviewing medication use, particularly high-emission anesthetic gases and inhalers, and promoting deprescribing where appropriate, and improving energy efficiency in buildings and operations. Adaptation strategies focused on strengthening disaster plans, educating staff and patients about climate-related health risks, and, for example, managing medications during heat waves and building more resilient supply chains. I suppose the session underscored that urgency, citing the IPCC warnings, but also the opportunity for pharmacy professionals to lead change, supported by resources and policy statements from organisations like the FIP and ASCO. The call to action was for oncology pharmacists to recognise their roles and actively engage in both mitigation and adaptation efforts within their practice. Tough thing to do, but something definitely worth considering and actively trying to do. The next symposium, featuring Tina Crosby and Mark Geinert, they featured in our episode yesterday on day one. And well, they were back today, and today they tackled considerations for improving administration efficiency in clinical practice of various multiple myeloma therapies. This looked at practical ways to optimize treatment delivery over several different ways. So the first part focused on pre-medications. Tina Crosby argued strongly against routine use of first-generation antihistamines like diphenhydramine due to significant risks, including sedation. So there was a study done to say that it was a more sedative and would impair your driving ability more than it was comparative to having being over the limit driving with alcohol. Cognitive dysfunction, and that was for a 50 milligram diphenhydramine single dose. Cognitive dysfunction, the risk of QTc prolongation, and the risk of drug interactions as well with diphenhydramine, with little evidence of superior efficacy for infusion reaction prevention compared to newer agents. So the second generation antihistamines like cetirizine and loratadine were recommended as safer, effective alternatives. The session also covered rationale for using two blockers like famotidine and mast cell stabilizers like montelukast in some pre-med regimens. Key efficiency points included swapping IV for PO pre-meds where appropriate, having patients take oral pre-meds at home, reassessing the need for pre-meds after initial cycles, especially for drugs like subcut daratumumab, where reactions are rare after the first few doses or even the first dose, and eliminating pre-meds where the risk is minimal. Studies from Chicago and the Mayo Clinic supported the safe omission of pre-meds for subcut dara after cycle 1 or dose 4 were presented. The second part, led by Mark Geinert, focused on dosing schedule efficiencies. A major highlight was the implementation of rapid infusion isatuximab. Data from a phase 1b study showed that switching to a 30-minute infusion after the initial standard rate infusions was feasible and well tolerated with very few reactions. So Cancer Care Manitoba's positive experience adopting this rapid infusion starting from the third dose, cycle 1, day 15, was shared as a real-world example of improving chair time efficiency. Licensed infusion rate is 72 minutes, but they've had great success with a 30-minute infusion. Other scheduling efficiencies discussed include carfilzomib, so a comparison of trials, so Endeavour versus the Arrow Champion 1 trial suggested that once weekly carfilzomib offers similar efficacy to twice weekly, but with potentially fewer grade 3 and 4 adverse events and significantly improved convenience. And again, bortezomib real-world data analysis indicated that once weekly subcut bortezomib was associated with equivalent progression-free and overall survival compared to twice weekly administration in newly diagnosed patients, but with a more favorable side effect profile, particularly less peripheral neuropathy. I would still say for those patients at risk of renal failure, the twice weekly schedule should be used until that is resolved. And finally, the session touched on future directions like home administration of bispecific antibodies and the potential for dexamethasone sparing regimens in later lines or maintenance settings. Overall, it was a really practical session highlighting evidence-based ways to make myeloma treatment administration safer and more efficient for both patients and healthcare systems. And so then we went into workshop groups then. So there was a split in which routes you could go down. So you could go today, there was a fundamental section which focused on data and research opportunities in putting those into practice. There was a hematology session, and then there was poster presentations. I went to the hematology session today, but hopefully I might get a bit of a lowdown on how the other sessions go, and I might be able to do some bit of a podcast on those. So the first of the hematology breakout sessions was by Katie Lecaria that gave an important presentation on opportunistic infection management in hematological malignancy with a specific focus on CMV. She began by explaining CMV pathogenesis, how this common herpes virus remains latent after initial infection, but can reactivate during periods of profound T-cell suppression, common after a allogeneic hematopoietic cell transplantation, HCT, but also seen with certain therapies like alemtuzumab or idelalisib. CMV reactivation can cause direct effects, viral syndrome, pneumonitis, GI disease, retinitis, and indirect effects, so immune modulation, increased risk of other infections, poor graft function, and increased non-relapse mortality. So two main prevention strategies were compared, which we don't currently do in Ireland. So this is giving an antiviral to all at-risk patients for a fixed period. So we do it for herpes simplex and varicella zoster, but we don't do it for CMV at the moment because we have no targets for it. Letermovir, a CMV terminase inhibitor, is now a key player here. Data from the phase 3 trial showed that letermovir significantly reduced clinically significant CMV infection compared to placebo when given prophylactically post-treatment, with a trend towards lower non-relapse mortality. Letermovir lacks activity against herpes simplex and varicella zoster, so other prophylaxis is still needed. So you'd need another antiviral in place there. And preemptive therapy then. So this involves routine CMV DNA monitoring, for example, weekly, starting the antiviral treatment only if the viral load crosses a predefined threshold. So that's often institution specific. I don't think there was any ranges given. So this minimizes drug exposure, but relies on timely monitoring and intervention. So standard agents for preemptive therapy included valganciclovir oral and ganciclovir IV, though limited by myelosuppression. Foscarnet and cidofovir are alternatives, but have significant nephrotoxicity. Management of refractory or resistant CMV due to mutations like UL97 or UL54 were discussed. Maribavir, an oral UL97 kinase inhibitor, showed superiority over investigator-assigned therapy like valganciclovir or foscarnet for achieving CMV viremia clearance in patients with refractory resistant CMV post-transplant. Taste disturbances, dysgeusia, is a common side effect. Other options for difficult cases, including adjunctive IVIG or CMV-specific T-cell therapy, though access to those is non-existent, really. This session concluded by emphasizing the importance of monitoring for CMV patients in receiving T-cell depleting therapies outside the transplant setting and tailoring prevention treatment strategies based on patient risk factors and available agents. So then we had Andrea Preston from the UK. She delivered a fantastic talk on risk stratification and treatment considerations in older or unfit patients with hematological malignancies. This is hugely relevant given the Asian population and the fact that most hematological cancers increase significantly with age. started again by outlining the complexity of managing cancer in older adults, considering the biological hallmarks of aging, reduce organ function, increase more comorbidities, polypharmacy, and potential psychosocial and nutritional issues. A core focus of the talk then was the importance of moving beyond chronological age and performance status to assess frailty and fitness using geriatric assessment tools. So we're a little bit aware of this in Ireland now with our geriatric oncology teams and clinics set up in Ireland. And this was set in the haematology setting. So very cool to see this applied in the haematology setting. So several tools were defined by her, so including the Vulnerable Elder Survey, the Geriatric 8 G8 score, Clinical Frailty Scale, Timed Up and Go, and the Myeloma Specific IMWG, so the International Myeloma Working Group Frailty Score. Evidence was presented showing that geriatric assessment consistently detects unrecognized vulnerabilities even in patients with good ECOG performance status. So acknowledging the barrier of time in busy clinics, the talk highlighted that validated GA screening tools can be completed relatively quickly, so around about 22 minutes, one study to get all of your screening tools done, and can be administered by non-clinicians. The simple gait speed test takes seconds to get done. Crucially, geriatric assessments isn't just for prognostication, it guides interventions. Identifying issues through geriatric assessment allows for targeted support. So it allows you to refer for medication reviews, referrals for cognitive assessment, physiotherapy, nutritional support, social work, etc. The Australian Integrate study showed that integrated oncogeriatric care significantly reduced emergency presentations, unplanned admissions, hospital beds, and led to lower early treatment discontinuation due to toxicity. The presentation also touched on adapting care for patients with specific impairments, so visual, hearing, physical, cognitive, using large print labels, compliance aids, simplifying regimens, and the need to improve clinical trial design to include older, frailer patients and relevant endpoints like quality of life and function. Exciting future directions mentioned, including exploring senolytics. They're drugs targeting senescent cells, which are active in the aging process, and using wearables and apps like the MyMM app for remote monitoring and patient empowerment. The key message was the need for holistic, individualized assessment using GA tools to truly understand the older patient's fitness for treatment and to guide supportive care interventions. So Marissa Ryan then, she presented findings from an ISOPP initiative mapping global oncology pharmacy service levels and knowledge requirements. This project aimed to understand the variation in oncology pharmacy practice worldwide and establish a common framework. A survey was sent to ISOPP leaders in 45 countries, receiving responses from 35. Myself was one of them. Key findings included that protected titles, pharmacist is a protected title universally. 100% of respondents said that. Pharmacy technician in about half, but oncology pharmacist is currently only protected in Singapore. This lack of title protection for oncology specialists was noted as a potential area for advocacy. Other findings from the survey included education. There's a global desire for advanced postgraduate education and certification like BCOP to enhance clinical research and managerial skills. The availability of masters and PhDs, residencies and fellowships varies significantly by country. The core output was the ISOPP Oncology Pharmacy Service Levels, a 7-tier framework. So this framework aims to foster global understanding, allowing countries to benchmark their services and advocate for service expansion. ISOPP's role in supporting this through advocacy, research, example on prescribing rights, and mentorship was emphasized. It's a valuable tool for understanding where different countries sit on the spectrum and where development might be focused. The final symposium of the day, you'll be glad to know, was hosted by EquiShield and asked the critical question, does your hazardous drug list adequately address the risks associated with handling hazardous drugs? I attended this session, which featured Dr. Melissa McDermott and Fred Masumi. Dr. McDermott kicked things off powerfully, presenting compelling evidence on the real-world risks of occupational exposure to hazardous drugs. She detailed exposure assessment methodologies using studies and discussed the documented health effects observed in oncology healthcare workers, ranging from acute symptoms to potential long-term reproductive risks and secondary malignancies. Her presentation made an undeniable case for why rigorous, evidence-based safe handling practices are absolutely essential, moving beyond mere compliance to a cultural safety. Following that, Fred Misumi took a practical dive into the cornerstone of these practices, the hazardous drugs list itself, focusing on the updated 2024 NIOSH list. He guided us through the changes and nuances of the new list, explaining the criteria NIOSH uses for classifying drugs as hazardous, so carcinogenicity, teratogenicity, reproductive toxicity, organ toxicity at low doses, genotoxicity, and structure toxicity profiles similar to existing HDs, hazardous drugs. The emphasis was on the need for each facility to perform its own assessment of risk. This involves not just adopting the NIOSH list, but critically evaluating it in the context of how specific drugs and dosage forms are actually handled within the institution. For example, manipulating tablets or capsules carries different risks than handling intact ones, and preparing or administering IV drugs requires different controls than dispensing oral medications. The discussion covered how this risk assessment, informed by an accurate hazardous drugs list, directly dictates the necessary engineering controls like biological safety cabinets, isolators, and closed system transfer devices, linking back to yesterday's closed system transfer device talk, appropriate personal protective equipment, selection for different tasks, and development of comprehensive policies covering the entire life cycle of a hazardous drug, from receiving and storage, through compounding and transport, to administration and waste disposal. The clear message that a well-maintained facility-specific hazardous drugs list isn't just a document, it's a fundamental driver for implementing effective engineering controls and work practices to protect staff. Go back to my very, very, very first episode on safe handling of drugs, and we kind of go through a lot of what was spoken here in this talk. So I suppose reflecting on day two, a couple of key takeaways stand out. From the first talk, PARP inhibitors. Management requires understanding genetic markers, BRCA, HRD, proactive monitoring, and tailoring strategies for common toxicities like fatigue, nausea, and myelosuppression, often necessitating dose adjustments. That clinical resource really would help with kind of standardization of those PARP inhibitor adjustments. From the second talk then, culturally responsive care. So principles of cultural humility, relationship building, and respecting diverse health beliefs, including traditional and natural medicines, are essential for pharmacists to provide equitable and effective care to all patient populations. Disaster preparedness. So oncology pharmacy has a critical role in ensuring continuity of care during crisis, requiring proactive planning, an all hazards approach, and clear roles and responsibilities for people. Multidisciplinary. Onto our sustainability talk. So pharmacy practice has environmental impacts, so emissions, plastics, pharma pollution. They require both mitigation, so reducing our footprint, and adaptation, preparing for climate hazard strategies. The myeloma talk. So opportunities exist to improve administration through safer pre-med choices, so favoring those second generation antihistamines and limiting the duration of utilizing them, adopting rapid infusion protocols, isotocimab was the example there, and utilizing evidence-based alternative dosing schedules. So weekly Bortez and weekly carfilzomib should be preferred where appropriate. Opportunistic infections, so CMV remains a major threat post HCT, and with certain therapies, effective management involves risk stratification, choosing between prophylaxis, if it's available, so letermovir, and preemptive strategies, which we currently do, and utilizing new agents like maribavir for resistant cases. Geriatric oncology, so assessing older unfit patients, needs to go beyond age and performance status, using geriatric assessment tools to identify vulnerabilities, so function, cognition, comorbidities, which predict outcomes and guide crucial supportive care interventions. And the global pharmacy standards, so ISOPP is working to define service levels globally, highlighting variations of practice and education, and providing a framework for advocacy and development. Watch this space. And the hazardous drug safety, so accurate, up-to-date, facility-specific hazardous drug lists, which should be informed by NIOSH, are the cornerstone for risk assessment and implementing effective safe handling policies and controls to protect healthcare workers. That concludes. I'm wrecked. our PAC Day 2 recap from ISOPP 2025. Another day filled with practical insights, forward-thinking strategies, and a strong focus on optimizing patient care and safety from various angles. I hope you're finding these daily dispatches useful. I'll aim to bring you the highlights from day 3 in the next episode. As always, if you have questions, comments, or suggestions, please reach out via Spotify comments. I'll post this up on LinkedIn. You can post it up, or you can comment on my LinkedIn, Instagram at Irish Heme Onc Pod, or email the Irish Heme Onc Podcast at gmail.com. Thanks for listening to this special ISOPP dispatch episode of the Irish Haematology Oncology podcast. Until next time, thank you. And there are disclaimers as always. This podcast is for educational purposes and reflects summaries of presentations that I've attended at ISOPP 2025. And the content of this podcast has not been reviewed or endorsed by ISOPP or CAPhO. The field of cancer care is constantly advancing. Always consult with your own clinical team and refer to local institutional guidelines and trusted national resources for the most up-to-date recommendations and personalized guidance. Cool. Thanks a million.